Welcome back to part 11 of our 20-part Dental Coding Masterclass series. In part 10, we broke down the CDT code architecture and the 12 categories of service. Today's explainer, though, is all about the absolute foundation of your revenue cycle. We're getting into the essential building blocks of compliant dental documentation, clinical charting, and exactly how you prove medical necessity for your claims. Okay, let's jump right in. To guarantee your claims can actually survive an audit, we're going to walk step by step through our roadmap, starting from the physical anatomy of the tooth, moving through clinical examinations and intake documentation, and finally drilling down into the precise CDT codes. Section 1. Dental Anatomy Fundamentals. We have to ground our coding in the physical reality of the patient encounter. Let's be real. You literally cannot accurately code what you don't anatomically understand. A tooth isn't just that white, visible crown sitting above the gum line. To select the right restorative, periodontic, or surgical codes, we've got to look deeper. We have to understand the root, the pulp cavity, and the surrounding tissues that anchor the whole shebang in place. When you're evaluating a tooth's structural integrity, it's absolutely crucial to distinguish between its anatomical layers. Take the enamel. That's the hardest substance in the human body, acting as a resilient outer shield against decay. But contrast that with the dentin underneath it. Dentin is softer, it makes up the vast majority of the tooth structure, and it carries those sensitive little nerve signals. When decay breaches that enamel shield and hits the dentin, that is exactly when your restorative coding really kicks into high gear. Going deeper down the root, you also have to understand structures like the cementum and the periodontal ligament. Cementum is that thin layer covering the root that facilitates attachment to the jaw. And the periodontal ligament? Well, that acts as a vital shock absorber when the patient chews, keeping the tooth securely stable in its socket. So why does this matter to us? Because these specific, deeper structures play massive roles in periodontic charting and surgical treatments. Section 2. Essential Dental Documentation Elements. With a firm grasp on the anatomy, we can move into the patient intake phase. This phase is the absolute foundation of your medical record, and honestly, it's your very first line of defense in any audit. Before any coding happens, this chart must be meticulously filled out. We're building a case here to justify the medical necessity of the procedures you're about to perform. A clean claim always begins with a comprehensive patient intake. To build an audit-proof foundation, your documentation has to capture these 4 mandatory pillars. First up, the chief complaint, or CC. This has to be the patient's primary concern, documented in their own words. Second, the history of present illness, the HPI, which details the exact chronicity, severity, and onset of those symptoms. Third is the past and present medical history, capturing systemic conditions, current meds, and allergies that directly impact dental care. And finally, the family and social history, where you're tracking genetic risk factors, oral habits, or tobacco use. If you miss any of these 4 pillars, your documentation is structurally unsound. Section 3. Diagnostic Clinical Examinations. Once that subjective intake is locked in securely, the provider transitions to the objective clinical exam. Let's look at what auditors expect to see here. A comprehensive diagnostic evaluation requires detailed charting across several fronts. You've got to document the extraoral exam, head, neck, TMJ, lymph nodes. Then the intraoral exam of the general oral cavity. You need specific hard tissue notes detailing existing restorations, decay, and missing teeth. Soft tissue evaluation is just as vital. You need periodontal probing depths, gingival inflammation notes, and, critically, oral cancer screening findings. Plus, you have to document the interpretation of any X-rays or diagnostic procedures. But keep in mind, these extensive, comprehensive evaluations aren't just for everyday routine visits. They apply to very strict scenarios. New patients, established patients who've had significant health changes, or established patients who have been absent from active treatment for 3 or more years. Coding a comprehensive exam outside of these parameters? Yeah, that is a massive red flag for payers. Section 4. Navigating CDT code categories. So, the exam is documented, and the physical anatomy is charted. How do we navigate the massive CDT code set to actually bill for our services? Well, the whole system is elegantly broken down into 12 distinct categories of service. This means you can easily identify the nature of a procedure just by looking at the first digit of the numeric code. For instance, the D1000s are your preventatives, prophies, sealants. D2000s are your restoratives, like fillings and crowns. D3000s handle endodontics, namely root canals. and D4000s are your periodontics, covering gum and bone treatments. It's a beautifully logical structure. But to apply these numerical codes flawlessly, you've got to master reading both the nomenclature and the descriptor. The nomenclature is simply the literal, written definition of the code. The descriptor, however, is a highly specific, written narrative providing the intended use and further definition of the procedure. Not every code has a descriptor, but when one is present, your clinical operative note absolutely must reflect its exact requirements. The specific surgical technique, the instruments used, the exact tooth numbers and surfaces, all of it. Section 5. Coding Oral Hygiene Instructions. Let's look at exactly how we apply a descriptor narrative in the real world to a common preventative procedure. This brilliantly illustrates the point. This is the exact descriptor for code D1330. It shows precisely how auditors expect your chart to match the literal definition of the service. You can't just scribble OHI given and call it a day. You have to actively demonstrate the individualized instruction. To successfully build D1330 and survive scrutiny, your operative note must explicitly detail that the education was provided one-on-one. You've got to document the specific guidance given on brushing techniques, flossing methods, dietary counseling, and any recommendations for adjunctive products like mouthwashes. Patient education is a procedure, so your documentation has to prove that the procedure was thoroughly performed. The incredibly good news for your revenue cycle here is that this robust instruction code D1330 can often be billed directly alongside standard procedures. It can be billed concurrently to the dental carrier with codes like D1110 for cleanings or evaluations like D0150. If you're putting in the work but failing to document and bill for it, you are quite literally leaving revenue on the table. The auditor's rule. Before we wrap up today's session, we have to look at everything we just talked about through the highly critical lens of an auditor. This right here is the absolute golden rule of all healthcare coding. No matter how exceptional the clinical care was or how much time you spent with a patient, if the chart lacks the necessary detail, you cannot legally bill for it, period. Complete documentation is the only thing that supports medical necessity, prevents devastating insurance clawbacks, and validates every single code you submit. So I want you to look closely at your own practice's clinical notes tomorrow morning. Really ask yourself, do they truly capture the complete physical anatomy? Do they contain all 4 pillars of the intake history? Do they explicitly hit the strict descriptor requirements we covered today? If not, it is time to upgrade your charting standards. That wraps up our explainer on dental documentation standards. Coming up in Part 12, we are expanding our code set and tackling ICD-10-CM coding, specifically looking at diseases of the oral cavity from K00 to K14, malocclusion, and Z screening codes. Be sure to like, subscribe, and share this with your revenue cycle colleagues. Until next time, decode healthcare with Harshal.